Okay, Bismillahirrahmanirrahim. Assalamu alaikum, everybody. Good evening. So today, as you see on the PowerPoint on the screen, I'm going to talk about ethics of rationing or allocation health resources in a pandemic. So as you can see now on the screen, I'm going to talk about ethics of rationing health resources in a pandemic. In the previous lecture, we discussed it was a theoretical one, and it addressed three key questions. The first one was why do we need ethics? The second one was how can we ethically approach pandemics? And the third one was what are the key values and principles, as you can see on the screen. So now, in this lecture, I'm going to offer an applied case on what we already discussed in the previous lecture. So in the second point, how can we approach pandemics? We discussed different points. One as the following: the difference between medical and ethical, if you remember this. Yes. And theoretical ethics, applied ethics, and key moral principles and values, and normality, necessity, and emergency. So we discussed in the previous lecture, we discussed all these points, which are key points now. Now we're going to try to show you how these points can be applied in a specific case or a specific example, which is scarce health resources. So this lecture will be applied, and it will focus on a case study, scarce health resources. Emerging theater pandemics can place extraordinary and sustained demands on public health and health systems and on providers of essential community services. So such demand will create the need to ration medical equipment and interventions. The rapidly growing imbalance between supply and demand for medical resources presents an inherently normative question which is how can medical resources be allocated fairly during a COVID-19 pandemic, and who should be treated first? So this is the key point that we are going to analyze and explore in this lecture. Likewise, if an effective vaccine is developed, it will take time to produce, distribute, and administer. So this lecture is divided into three sections, as you can see on the PowerPoint. So in the first section, I'm going to talk about the interdisciplinarity character, and I will link this case to our previous discussion on the differentiation between medical and ethical aspects. And in the second section, I'm going to propose or to discuss proposed guidelines, whether they are I will take two examples, secular examples, and two another examples from within the Islamic discussions or Islamic approach. In the third section and the last one, I'm going to suggest framework, a theoretic framework, and guidelines how to solve this problem or how to respond to this how to respond to this dilemma, ethical dilemma, which is the scarce of medical resources. So let's start with the first section then. So I would like to start the first section of this lecture by asking the following question that you can see on the screen. So, and I prefer to hear your opinion about this question. The question is, during COVID-19 pandemic, prioritizing some patients over others is a life-death decision. Who has the right to make this decision? What do you think? It's better to speak out, to have a kind of interactive discussion instead of just writing. So anybody would like to say his opinion or her opinion? Independent committee. Independent committee.
Assalamu alaikum.
Alaikum salam.
I would argue that it's more of a responsibility than a right. So whatever body or government or authority who is setting all regulations for protection, for example, the lockdowns, etc., has the responsibility to set those guidelines or to prioritize patients, not necessarily patient by patient, but set the guidelines, because failing to prevent the disease through regulations will cause that influx of patients.
Okay. Other opinions? I would like to speak.
For me, it should not be the government or like a government policy, but I think for me it would have to be a clinical assessment of the utility of the intervention. So I would probably say that the ones that have the right to make the decision would be the clinical specialists that can anticipate what the utility is of the intervention and who have the best view of whether it's useful or not. So that would be more of a utilitarian argument, I guess. But I would also say don't forget the voice of the patients in this regard. Because right now, at this moment, we notice that in the triage, patients are not really asked whether they even want to be intubated or not. I've noticed this in my own hospital where I work, where it's kind of assumed that all patients want to be treated with the ventilation machine, but they are not really asked or don't really have the time to even consider whether they want that or not. So I would say make it a clinical decision, but do not exclude the voice of the patients.
Yeah, but the patients have contradicting opinions, because in this case we are suffering from scarce resources.
Of course, but
so each one will prefer to be prioritized. And so who is?
Yeah, but don't just assume that young people all want to be treated that way. That's a assumption. You can always ask themselves whether they actually want to or not, which may solve some of the problems. Because if young patients would say, you know what, I don't need this, I don't want it, then that gives room for other people, to distribute it.
In this case, should we listen to the patient's opinion just in the case of negative rejection, the treatment, or in?
No. I would say make it the right. It has to be with the clinical specialist, but include the voice of the patients there, and don't just disregard it.
Okay. Okay, but how can we balance in this case? Because we will have contradicting opinions. So what should we do in this case? We have like 100 bed, and we have 500 patients. In this case, each one would prefer to be the chosen one.
Yeah. So in my view, the clinical specialist would determine the overarching parameters. For example,
Mm-hmm.
they could say, you know what, for a specific group of patients, like people with high risk, morbidity risk, and that kind of thing, those people should probably be excluded. Okay, so that's the clinical specialist anticipation. But then once you do decide, okay, this patient is in the this patient is okay with the criteria, if we include this patient in the criteria, then don't forget to ask the patient if they actually want to proceed or not with the treatment.
Okay, thank you very much. Any other opinion or comment?
Yeah, I want to point out that sometimes we also have to see which kind of committee is better not to use. Like, as a person who works in the fight against discrimination, I would say that I'm really concerned about committees that are linked to governments or to policies. Because sometimes some political party could have the interest not to treat some person, like discriminated groups. So we should have a committee which is independent and link more to healthcare than to politics.
Okay. So do you think the independency can be guaranteed through a committee or through a clear policy?
Well, of course, committees and even experts, and I have a lot of experience in this field, even doctors can discriminate. So it's because each person has his own political opinion. And of course, they should not, but they reflect that opinion in their work. So yeah, it's very, very complicated, but maybe having a wider committee could be better. And not just one committee with one opinion or coming from one experience, but some wider group.
So if everybody has his opinion and might be biased, then being an independent committee or government committee, it doesn't play a big role, right?
Yeah, but when it is more linked to the government, it has one political idea that can be very dangerous, especially in some countries. I think about Eastern Europe or even some Western European countries, which nowadays are like pretty much against, I don't know, refugees or religious minorities. So yeah, they could say, okay, refugees are foreigners, so we don't need to treat them. We have to think about our citizens first. So it's really dangerous, I think, to link a committee to the government.
So you prefer an independent committee then?
I would like to comment, Dr. Muetaz, because I want to focus a little bit on the medical staff crisis. For example, what happened in north of Italy at the beginning of the crisis, and which is considered a strong medical system, by the way, in the north of Italy, and still were overwhelmed with patients. And the medical staff at the beginning was alone in the field, and doctors made decisions according to what is available and who comes first. And afterward, even the decision to disconnect patients or hopeless cases from the ventilatory machine was a very, very tough decision. and they could not make these decisions on their own. And even an article was written from the north of Italy to describe this experience, calling for help and suggesting a committee that was, in my eyes, it was a good or some kind of a solution, because it was government independent, but it was a local committee in the hospital that included medical staff members who could describe the objective findings and talk about prognosis, which, prognosis is not an optimal way to describe the situation, but it's the tools that we have as doctors. And then some other members from other fields could help in making the decision according to economic availability of equipment. So I'm not sure that we have a good answer for this question, and we could hear what you have to say.
Okay, so to avoid politicizing the question and the issue, what this committee should comprise or consist? Like medical doctors, ethicists, religious leaders, who should be there in the committee?
I think it's quiet. I'm not sure if anybody has the right to make the decision, because the right here is more assigned. So somebody assigns this right to someone.
Mm-hmm. So because at the end, patients will go.
I think this right is related to the knowledge, to the comprehensive knowledge of the situation.
At the end, all patients during pandemics, they go to the hospitals.
It's like the right to have a decision over someone else's life.
Yeah, it's not over his life, but at the end,
Excuse me, Aya, but also, Aya, even not making a decision in a way is making a decision.
Yeah, maybe.
Not making a decision in these cases is a way of making a decision of compromise.
I know, but I want to make a point. Yeah, but I've not finished my point, Niveen, if I'm allowed, please, too. So what I'm trying to say is, everyone has the right to die over someone's life. Nobody is given this right by birth, right? So everyone has the right to life, and everyone has the right to have her or his life saved. So I think when we say that someone is assigned the right to take this position, they should stand at an intersection of different positions, and this means having multiple knowledges, or at least in this committee that's going to decide on who's going to be saved or not, having a multiplicity of knowledges. So the first knowledge has to do with maybe what people understand according to which this society is operating. The second thing is knowledge of medicine. What else? I don't know. Yeah, so it's like our people that relate to the community itself, or how to communicate this to their families. So I think there's the person who takes this decision must have many people of this knowledge. Yeah, I'm done.
Okay, thank you, Aya. So this example and the purpose of this question to show you the complexity of the issue or the case study that we have at hand, because it's not just an individual right or the patient's right, because we have now different rights here, and we have different values, and we have to balance between them, because each patient has the right to be treated, but at the end, the capacity to treat everybody is not there in this case, and then there is a high demand and high needs, but at the same time, there is no capacity to cover all these patients' rights. Then this is why we have dilemma here, and then so we have different parties different parties are involved in this dilemma. So this is why it's complex and not easy. This is what we call dilemma, ethical dilemma, because the solution is not clear and it's very complex. So this issue is novel, as you can see, and complex. So it seems to have a medieval character in the modern world, where technology is one of the main characteristics of our world. To have very limited resources, health resources, and you have to choose that to exclude whom and to include whom, or give priorities to whom, which is very, very tough and very harsh decision, and it might cause a lot of contradicting opinions and struggling between different parties. And then at the same time, coronavirus outbreak returns us back to the question of differentiating between medical and ethical, as we discussed in the previous lecture. So who will make life-death decisions in this case? Because at the end, yes, it is a life-death decision with many cases, because it's an emergency case, and we don't have enough resources to cover to treat all patients. So the question here is not only who is going to take the decision or who has the right to take the decision, but it's also the most important question here is based on what we will choose or include or exclude some patients or prioritize some patients over others. This is the most important question. So I would prefer to say that it's not a matter of who is taking the decision, but rather it's a matter based on which criteria that we are going to take this decision, and these criteria should be transparent and known for everybody in the society. At least we can observe ourselves. Not only the committee know what is the criteria, what are the criteria that they choose based on, but we know even patients and families and relevant to these patients. So everybody in the society should know what's going on in hospitals and what are the criteria, what is the policy, and to check, even to observe if this policy is applied accurately or not, or if there's abuse of applying this policy or these criteria. So the more relevant question is to discuss the criteria and the foundations of prioritizing patients. So the complexity of scarce resources provoked the British Medical Association to say that there needs to be an urgent public debate about this issue in these unprecedented times. So because, as we can see from your comments, it's very complex and it's not an easy question to answer. So we need a huge discussion from different disciplines, and this is why we call it interdisciplinary case study, or this is why we call bioethics in general or ethics in general as an interdisciplinary field, because different disciplines should be involved in this piece. give a word. So this means that ethics and law should also be involved in this case, not just medical doctors, not committees, and these committees should follow a clear rules or policy that it's legal and ethical at the same time. So the issue at the end, it's an interdisciplinary issue, and it has interdisciplinary character. So the question here is not whether to set priorities, but how to do so ethically and consistently. So to avoid manipulating or abusing this policy or this case. So rather than it's basing decisions on individual institutions, approaches, or clinicians' institution in the heat of the moment. So I think this is enough for explaining the complexity of the case at hand. And let's move to the second section of this lecture, which is in this section we will discuss different examples or proposals submitted by different institutions from different backgrounds to solve this problem. So, but before that, I would like to ask you the following question. Is it lawful or ethical to set a person aside for non-treatment? If yes or no, so if yes, so what are the criteria? And will this impact on equality or discrimination or not? Please keep in mind that we have a very limited resources and we have a huge number of patients. This is the case at hand now. So like we have, so our resources are not enough to treat everybody. This is the case.
Assalamu
alaikum. Alaikum.
I personally think that when it comes to criteria, I think we can adopt some of the criteria we already use in the cases of, for example, organ donation. A lot of times we look at someone's risk for getting better. For instance, if they're a drug abuser or an alcoholic, we could adopt some of those criteria in this case.
Mm-hmm.
And I think when it comes to the impact on equality or discrimination, that's where I'm a little unclear on how to, or where I'm a little bit worried. For instance, there's patients that would be like, there's some criteria that were proposed by the British government, and one of their criteria was the QALY. I don't know if you're familiar with that one. The QALY criteria, the QALY metric.
Mm-hmm. So what is it?
So it's a point system where they use the base, like they have I'm not entirely clear on how they calculate it, but it's a point system. And if you have more or less of the points, that determines how high on the criteria list that you are. So some of the patients that I'm more concerned about is patients with disabilities. They would technically fall lower on the quality metric, but that would subject them to discrimination. So that's where I'm a little iffy about. Yeah.
Is it applicable for? Does it apply for emergency cases like coronavirus?
Yeah, it was made for coronavirus.
Oh, okay.
Yeah.
Okay.
I can find the article and look at
on specific points to calculate them and then to prioritize patients.
Yeah. Yeah.
Okay. So. Okay. Are you done?
Yes, I'm done.
Okay. Thank you very much. Any other opinion? Do you have suggestions for the criteria, and based on what should we prioritize patients?
Well, I think it's quite unethical to set a person aside, but yeah, you have no other option, so yeah, we have to do it. And I think you don't look at the person personally, who he is, but you should look, I think, at the chances of recovering, their quality of life after recovering, and the years to live after recovery, because you can treat the person who has little chance to recovery and then they die in the end anyway. But yeah, it still remains an unethical decision, and nobody wants to make that decision, but I think we have to.
Mm-hmm. Okay. So now you proposed two criteria, like
Yeah.
Can you repeat them?
The chances of, I think especially the chances of recovery and the quality of life after recovering from COVID, and the years to live after COVID.
Okay. So now at least we have at hand two criteria. Okay. Any other suggestions?
I would agree with the chances for recovery, but not with the quality of life, because that means we're discriminating against people who potentially have already comorbidities or who are already in a worse situation. So as if we're just choosing people who are economically feasible.
Mm-hmm. Okay. Any other opinion? So now we have an agreement between two commentators on one criteria at least. The high possibility to recover. Do you have any other suggestions?
Yeah, yes, we might add the healthcare workers, that they benefit the society in general, not only on an individual level. So I think that they have the right to be the first ones.
Okay.
To be treated, yeah.
Should this come from before the high probability of recovering, or after?
I think it should be at the second level, yeah.
At the second level.
Yeah.
Okay.
Yeah. Thank you.
Mm-hmm. Any other comments?
So maybe just to respond to the previous one. So if we have two persons, one is a disabled person and one is not, and both are on treatment. So does disability come as a factor for criteria to decide which one worth life more?
This is a good question. So what do you mean by the quality of life? Would you like to answer?
Yeah, this is for Nadia. Nadia, right?
I'm not sure. I think, yeah.
I didn't mention the disabled people. I just talked about the healthcare workers.
No. The one before you, I think.
Yeah, exactly.
She mentioned two criteria. One of them is the quality of life. So the question here now is about what does it mean? What does the quality of life mean here? And does it apply for disabled people?
Well,
are they low quality, lower than the others?
Well, I think if you're having a disability, you don't necessarily have a bad quality of life. I think I mean more of that. If you're recovering from COVID, if you're having certain things, it might still affect your body afterwards, and it might be worse with some other people than others. And it doesn't necessarily mean that if you have a disability, you have worse quality of life. I think it's more what the disease does to your body, and maybe your quality of life is affected much by it, that your life is getting difficult because of the things COVID did to your body, and your life will be quite hard after COVID. But it's difficult because you still have the right to live, and yeah, it's a decision nobody wants to make, but yeah.
So is it a long life or like It's a number of years, or the way of the normality of life, like based on what he or she used to be?
Yeah, I think that's the last point, but yeah, it's never, you can never measure it like it's exactly that way or that way, because years to live, you can still be hit by a car tomorrow. So yeah, it's a very complex issue. What is quality of life?
At the end, we need to measure it, because to prevent abusing this criteria, because some doctors will come and say that, okay, disabled people have low quality life. Then, okay, we can keep them aside.
Yeah.
Or Mongolian, people, or any people with a specific type of disability.
Yeah, they can still have a very good quality of life, and somebody else who is not labeled as disabled, but their body is very heavily affected by COVID. I have still a worse quality of life after COVID, but that's are things you never know beforehand, so that's difficult.
Yes, the concept of quality of life is a controversial one, and we need to measure it. And to put criteria again for this criteria,
I think it's also like, even if we don't take it on disability level, we can take, there's a scientist who has COVID-19 and there's a homeless person who has COVID-19. So when we want to judge the quality of the life of the two, so I agree. I think it's a controversial, and I think at the end of the day, also taking a decision about who stays on the bed and does not takes a layer of this. It is at some point discriminatory, because we're going to assess whose life is worth living more than the other.
Yeah, there are also minorities, ethnic minorities that suffer from discrimination. They have a high rate of unemployment and high rate of bad housing. So they have a bad quality of life. So we have to be very careful about that. I agree with Aya.
Okay, let's move to another point. We will have more chances to discuss. Now, in this section, we will discuss 4 proposals to solve this ethical dilemma, 2 secular and 2 Islamic. And we will see, we will discuss each one of them, and we will see their proposals and their suggestions or recommendations, and then we will discuss them and analyze them. So let's start with the first one. The first one is the British Medical Association. So the British Medical Association issued the ethics guidance that suggests the following points that you see on the screen. But I prefer to play the audio that they even published.
My name is Julian Sheeter, and I'm a special advisor in
Can you hear this?
Ethics and Human Rights for the British Medical Association. My colleagues and I, in recent weeks, have put together a suite of frequently asked questions designed to address the most urgent ethical issues that doctors are confronting on the front line during this pandemic. Doctors are going to be working under extreme pressure. Many will be working in new, relatively familiar areas of practice. Some will be acting at, or even at times beyond, the level of their competence.
Okay.
Retired doctors are returning to practice. Final year medical students are being fast-tracked into frontline roles. We recognise that in these circumstances, doctors may struggle to meet existing standards of practice. They will understandably be concerned about their own well-being and the well-being of their patients and of those close to them, friends and family. Quite understandably, they'll be concerned about professional, even criminal liability issues. In order to address these and other concerns, we've put together a number of FAQs designed to address some of the most challenging ethical questions doctors are likely to address during this pandemic. One of the questions doctors are asking us about is triage. Is it lawful? is it ethical to set a patient aside for non-treatment where other patients have a greater capacity to benefit or to benefit rapidly from the treatment available? Our guidance is clear on this. All patients need appropriate, compassionate care. However, in some circumstances where health need absolutely overwhelms available supply, it is legal and ethical to say, okay, we are going to prioritize some of these patients who have a greater capacity to benefit or a greater capacity to benefit more rapidly, and therefore they are going to get priority access to treatment. These decisions can be challenging. It is likely that many doctors will find them distressing. It overturns ordinary medical instincts. Nonetheless, it is clear that it is both legal and ethical in these extraordinary circumstances. So what kind of criteria might be relevant? Well, obviously the severity, the impact of COVID-19 on the patient, also underlying comorbidities, and where clinically relevant, any underlying frailty. It's worth adding as well that these decisions about triage don't only apply to questions about whether to start treatment. In some circumstances, it can also be appropriate to say, we've made every effort with this patient, we've started them on the treatment, but they are simply not responding, or they are not responding anything like rapidly enough. And it is because services are so overwhelmed, it may be appropriate to say, we're going to set this patient aside now for supportive or palliative care, and we're going to prioritize other patients who have a greater capacity to benefit. Another question we're hearing a lot about from doctors is whether or not triage type decisions will impact upon equality or anti-discrimination legislation. One of the things we recognize, one of the things we know about COVID-19 is that it does have a greater impact on the elderly, particularly the frail elderly, and therefore some triage decisions may give rise to questions about indirect discrimination. Our position is clear though. Provided doctors are making decisions based upon clinically relevant factors, it is appropriate to triage in these ways. There mustn't be a simple age cutoff. The presence of a disability by itself must not be given as a criteria. However, where these factors are clinically relevant to decisions about whether patients are going to benefit, then they can be taken into consideration. Among the most urgent, pressing questions we're also being asked at the BMA is about personal protective equipment. We're hearing a lot of stories about doctors being concerned about being asked to treat patients where their protective equipment is either inadequate or even not available. Our position on this is clear. If you are asked to undertake an aerosol generating procedure in relation to a patient, and you do not have PPE, or the PPE you have is clearly inadequate, you are not under an obligation to provide that treatment.
Okay, so this is the guideline recommendations and guidelines for doctors to apply in this during this pandemic, COVID-19. So now, what do you have any comment on this issue? Do you agree or disagree with some of these elements or criteria?
Yes, I just wanted to say that he's right when he says that it's not about disability or elderly or young people, but the factors of the chances of getting better with that treatment. Even if a disabled person, the disability of that person is not directly involved in the treatment, it won't affect the treatment, so it won't be taken in consideration. I think that's a fair point he mentioned.
So
it's not a straight answer, but we need to look at it case by case. But the predominant criteria or factors are: is this treatment going
to make a difference in the life of this person or not? What are the probability of success of the treatment is more relevant than the status of the patient himself.
Okay, let me just try to help you to analyze this video and the content of this video. So I believe that the video is, the audio is talking about 3 key points. Number one is, what is the recommendation, as you can see on the screen. Number two, what are the criteria? Number three, what is the governing value behind this criteria and recommendation? So can we just try to remember? So what is the recommendation here, or the fatwa they established? They said that it's illegal and ethical in these extraordinary circumstances to prioritize people. So this is the recommendation, or the statement, the general statement now. So what is the criteria? Why, based on what it is legal and ethical? Capacity to benefit. Okay, so the criteria, he said clearly, that is based on the capacity, or the patient who have a greater capacity to benefit or to benefit morbidly, they can be prioritized and get access to treatment. So this is their criteria. Now, what is the value behind this?
Compassion.
Mm-hmm. Any other? Do you agree with this, or what? Or disagree? Any other comments? Is there another value?
Human life.
He didn't mention clearly, but we have to analyze it, you know. So maybe human life, but if you will say human life, but we are, you know, there are some other human lives not prioritized and left aside. So in this case, we didn't achieve this value completely, at least, you know. So they raised, there was one question talking about equality and discrimination. So, and he answered this question. So what was the criteria to avoid equality impacting negatively equality and discrimination?
Justice.
Justice is a value. He was talking about the criteria to which doctors should follow to avoid being questioned legally, considering only clinically relevant factors. Great. This is the criteria that he mentioned. So at the end, it's measured, and it can be examined or discussed. So the only criteria that he provided for this case to avoid being, you know, to avoid being or to impact negatively equality or discrimination, is that the decision of the doctor should be taken based on only clinical relevant factors. So this is these are their recommendations and guidelines for doctors to apply in UK. So do you think this is fair enough? Do you have this? Do you disagree with any of these elements?
Assalamu alaikum. I think the issue is going to be more complex step by step as we talk about prioritize the patient. When we talk about who benefits more, I think after this step we should talk about between two patients that they are in an equal way. So the matter of age became here, and also maybe the matter of social class. We should talk about that and include in our decision. I think after we can say because in the case of COVID-19, we see there are lots of patients and a little resources. So we should, I think, be more specific about the order we talk about, and it's not, and we can't say who benefits more, as the doctor mentioned in the audio.
So what's your suggestion in here? Which criteria do you suggest now to add? Can you formulate your suggestion in like in a criteria to add it to this list?
I think maybe after, because in the case of COVID-19, the matter of time is very important. I think after who benefits more, we can add who benefits sooner.
So, but he was talking about the greater capacity to benefit. The beneficiary here is restricted or is defined by medical information or clinical relevant factors. So it can be measured. So what's the problem with this? Why it's not enough or it's insufficient?
Maybe I think we can't measure all aspects of these clinical issues for each patient.
No, we can. Why we cannot?
I think because the matter of time. When the emergency patient, you face the emergency patient, how you don't have time to measure these factors. In this case, what should we do? We can measure their health problems or something like that, and even the chance of recovery. So what should we do when the ambulance bring the patient to the emergency, and so the doctor should make decision that it is the emergency patient, or prioritize the patient, or prefer the patient to the others. Here, I think we can measure immediately these factors. It takes time.
Okay, to analyze the content before you comment, sorry. To help you to analyze the content, I classified the content based on what you see on three criteria, as you can see on the screen. Guidelines, criteria, or three categories: guidelines, criteria, and value. So, okay, go ahead, please.
No, I was just, I wanted to respond to Ali. It's possible for doctors, given whatever education they've had, to kind of measure the status of a person. I think what's more difficult for them is to be able to anticipate the capacity to benefit. So when people are put on intubation or in ICUs, usually they're not able to anticipate how long that would take for them to benefit.
Okay. So can you look at the screen and see the point that I classify them, and see if you can add? Do you have something to add to make the decision more ethical or more accurate or more fair? is there something missing?
Like I've said earlier, at this moment in time, I don't think there's a register that on which patients or provisional patients can register whether they even want to be intubated or not. So maybe in the future that could be added.
Okay, any other comment?
I just want to ask a question about what's your idea about the differences between the equality and justice? Can we mention these differences between the meaning of these two words and put it here?
Okay, this might take time. Okay, I can comment on this at the end of the lecture because we still have many issues to discuss now. So I will come to this point later before we end. So now we have three criteria or three categories. Sorry, the British Medical Association issued these guidelines and recommendations for doctors, and now we know they were clear about their criteria, and these criteria are based on scientific factors, and they demonstrate that this, or at least justify that these factors do not impact the value, the key value here, which is equality and discrimination. So these recommendations, they think or they believe that they are aligned with the key value, which is equality here, that each patient, it doesn't contradict this value. So I have the feeling, just to conclude before we have another example, and then with all the four examples, the picture will be clearer and deeper maybe. So my feeling from this, or my point here, I have the impression that this position was more practical to guide doctors, and it is busy with legal concerns more than ethical concerns, because it didn't cover all the problems, the ethical values and how these values can be balanced. They only covered equality and discrimination, because this is a controversial and legal issue. It's ethical too, but it has more legal weight in UK. So this is why they addressed this issue, this key issue here, to say that it doesn't contradict. These recommendations do not contradict this issue, and then the doctors will not be questioned in front of the court or by the law, the UK law. This was my comment on this, but it's still, I think these criteria are sufficient and clear, and they are measurable. I mean, the impact of COVID-19 on the patient, which is clinically, which is a clinical factor, and this impact can be measured through severity of acute illness, or presence and severity of morbidity, because those people who have other diseases, it will be more hard for them and they need emergency intervention. So it's not equal with the one who is healthy and he got the virus. So because he can recover maybe without medical intervention, or he can go, the impact of the COVID-19 will not be that hard as those people who have other diseases. And frailty, how can we pronounce this? Frailty, or where clinically relevant age, because we know that he supported his point with a scientific statistic or factor, which is that we know that COVID-19 impact or affect deeply the old people more than young people. So these are the criteria that he listed and recommended for the doctors. Let's have another proposal. The second proposal is stated in an article published in the New England Journal of Medicine. It was written by a group of authors, like I think 9 or 10 professors. These professors came to the conclusion, they listed 6 recommendations, and they listed 4 values that these recommendations are based on. So the recommendations are, as you can see on the screen: maximizing benefits, prioritizing health workers, do not allocate on a first come, first served basis, be responsive to evidence, recognizing research participation, and finally apply the same principles to all COVID-19 and non-COVID-19 patients. So these are their recommendations. There are 6 recommendations, and they believe that these recommendations are based on, after their study and analysis of previous studies, they believe that proposals for allocation of resources in pandemics and other settings of absolute scarcity converge on 4 fundamental values. These values are maximizing the benefits produced by scarce resources, and treating people equally, and promoting and rewarding instrumental value, and finally giving priority to the worst off. So now the question is, do you find this framework convincing or more concrete than the previous one? Or what do you think? So now we have 6 recommendations and 4 values.
I wish if you could please elaborate more on what does it mean to recognize research participation and apply the same principles to all COVID-19 and non-COVID-19 patients.
Okay, so to have a vaccine to prevent this virus or to recover from this virus, then it needs some volunteers that to be tested. So these people will have the priority. This is what they meant by research participation.
Okay, I find these guidelines less convincing than the ones before. What I liked better about the British recommendation is that they are more flexible, in my opinion, because they give the clinical course, the the specific clinical course more value than other values. Here, I think even there are some contradictions between the recommendations and the mentioned values, like treating people equally and then directly prioritize health workers and research participants, even without an explanation what is the far benefit from that in promoting health or public health. I think it's a slippery road a little bit because it's an opening door for discrimination and not for equality. I think it's more, it's harder to implement the recommendations according to the values. Maximizing benefit is not a term that is used usually in health services because it's not really clear. Apart from the next slide that you wrote, that if you can show us again, Dr. Muetaz, the next slide, if they mean by maximizing benefit, saving more lives and more years is a consensus, if this is the maximizing benefit, it's something that I can't understand, but it's again something that's very, very hard to evaluate at decision time.
Okay. Actually, they discussed in details some of these recommendations, but I just listed them. I gave you the conclusion. But one of the applications of maximizing benefits is saving more lives and more years of life. And they said that it is a consensus value across expert reports. This is the quotation from their research.
More years of life sounds to me a very problematic value, something to evaluate. And to talk about it as a consensus, I'm not sure that is true.
Yeah, and I agree with that being problematic because it will always favor younger people who are, again, more productive for the economy. And that's the most important reason, I think, for them to prioritize them compared to other people. But if we compare this New England, or this proposal by the New England Journal to the British model, or the first one is more measurable with the criteria that they set. And that's probably to make it easier for people and to save them the issues, the legal issues. But this one has more doors for prioritizing those who are not COVID-19 patients, who usually get lost situation. So it does open more doors for equality. What I would like to also comment on is, while they recognize research participations or participants, and that's obviously a good thing to do, I don't know if they mentioned that, but we also need to think about the police, garbage collectors, anyone who has to sustain services for the community, who has to go to work and sustain services. So those people are, again, doing something for the community. And if they get exposed to the virus and get sick because of this, they should get some prioritization.
Okay, good point. So do you notice that number one in the recommendation is maximizing benefits, and number one in the values is maximizing the benefits? So what do you see in this point?
Assalamu alaikum. Both of these systems are maybe implicitly the British one and explicitly this New England Journal. They're utilitarian in their focus. You know, the utilitarianism and its logic are informing its decisions. And an Islamic approach may end up at a similar conclusion or similar conclusions, but I think the pathway would be different. So you might end up with looking at maqasid and the objectives, or maslaha and the public interest. You might look at preservation as your guideline, and in the values, you might look at things like necessity of making decision, the lesser of two evils, reducing harm, intentionality. And so I think the tools would look quite a bit different than these. and maybe deal with some of the problems that utilitarianism presents?
So I think that maximizing the benefits, they repeated the same point in their recommendations and in the values. I think in this case, they mixed between values and recommendations. So because maximizing benefits is a very general, and we can agree on it as a universal value, or I mean general value, not universal in the yeah. So in the Arabic word, it's kulliya. It's not kawniyya. You know, it's not global. It's universal but not global. So we can say that, okay, this is a universal value, but we cannot consider it as a recommendation, because the applications will be very different and controversial in applied cases. So we cannot say that recommend doctors to maximize the benefit, but based on based on what? That you consider this as benefit or you know, greater benefit. So again, we will face another question. So based on which criteria you consider this as benefit, you know? So the quality of life can be considered as benefit. So again, in this case, we will be in the in this case, we will be utilitarian, as you mentioned. Sorry, Logan, huh? Right? Okay. So this is one of the points, the critical points on this issue. There are other points. So maximizing, I already said that maximizing the benefits is a universal value and can be operationalized in different ways. So some of them can be controversial, like, for example, how can we balance between lives and life years? Because both of them, you know, saving lives and saving, you know, life years, both of them can come under maximizing the benefits. So in this case, should I prioritize young people over the old people, because we will maximize the life years in this case? Like, and this happened in Italy, for example, during COVID-19, and it was a controversial issue. And this will lead us again to prioritize to leave aside disabled people, and this was discussed in one of the United States, and it was a controversial issue at the same time. You know, so it's you see that we can have different applications of the same value. So it cannot be a recommendation. Okay, it can be a value, but it cannot be a recommendation, because the recommendations should be clear and measured and practical to apply and to be measured. So one of the problems, for example, if we will say that you know, life years can be a criteria, and it can be considered as maximizing benefits, then the limited time and information during an emergency case make it difficult to incorporate patients' future quality of life and quality adjusted life years into benefit maximization. So So it's not that easy to apply or to implement during emergency cases. So at the same time, it's time consuming to collect information and would present ethical and legal problems if you are going to maximize the benefits through taking life years in consideration as one of the criteria. So, and even though the point that we already discussed earlier, who is going to decide or define what the quality life is, you know? And in this case, should we document what future quality of life patients would regard as acceptable? So if yes, then we will. This takes time, you know, and we need to document all this information and then to come to a conclusion that, okay, this quality life is considered and this quality life is not considered, you know. So it's really problematic and controversial in my opinion. So I find it weird that they that they said there's a consensus on this issue by experts. Maybe there is a consensus within utilitarianism, but not in general. Now, operationalizing the value of maximizing benefits means that the priority will be given to people who are sick but could recover if treated. This is one of the applications of this, and we agree on this. You know, we can agree on this, of course. Those people who are sick but could recover, it's considered as one of the criteria. But maximizing life also means that to give the priority to those who are worst off in the sense of being at risk of dying young and not having a full life. But there is no clear guidance which one comes first. You know, the worst off or the sickest people or patients. Which one is comes first? And how can we prioritize these two criteria? So it's not clear, and both of them can be included under this general value, which is maximizing benefits. So this approach, in my opinion, seems to be centralized on utilitarianism, which is reflected through maximizing benefits as a key value in this framework. And it took much more space in their article than the other points. Even though they try to, in one paragraph, they try to show that there is a kind of consensus on some points, you know, even out of utilitarianism, but I believe that this is not the case, you know. Now let's move to the third example. The third example is a fatwa issued by the European Council for Fatwa and Research, and their fatwa, as you see on the screen, you can have a minute or 2 minutes to read it, and then think of it and try to comment and say your opinion and what do you understand from this, based on the same question that we asked before: the criteria, the value and the guidelines. What do you get from this fatwa?
So for me, what seems apparent is that there's more of an acknowledgement, or at least the very note even, that an individual human life is paramount herein, which I don't think was mentioned in examples before this. So this council, they acknowledge the individual human life and these human principles. But if I look at it very closely, practically, it's not that different, because we see here that if the physician has no choice but to choose between two patients, then again, a futile treatment is an important criteria, and again, the treatment that is more likely to have success is also an important criteria. So I think the only difference here that I can see is this acknowledgement of individual human life, but practically it seems, for me at least, not that different from the first two.
Any other comment? Thank you very much for this comment. I agree with you. Any other comment?
I have a problem with choosing the first patient, if they mean the first come, before other conditions or other criteria for.
Why is it problematic?
Because the first person to need the service is not necessarily the person who needs it most. And that person might be there because they have they're just at the hospital when it happens. Another person is not at the hospital when they need the treatment. So,
or living in the next building.
Or living in the next building.
Okay, so it's not fair. Let me help you to analyze this text and rearrange the content in that way. You can see on the screen now, I rearrange the content, the substance, in differently by classifying the content in this way that you see. Guidelines and criteria. The guidelines are responsibility, to define the responsibility, who makes decisions. Number one is they started with giving the administrative and medical regulations. It comes first. You have to follow, as a Muslim physician, they said that you should comply with the administrative and medical regulations. This is number one. Now, number two, if the decision is assigned to them, to the Muslim physicians, then they must utilize medical, ethical, and human principles, which is very general, and it doesn't affect the complexity of the case at hand at all. Because as we saw before, from the previous examples, it's a controversial issue and it's not clear. So what does it mean to utilize medical, ethical, and the human principles? So it's very general. It's a kind of preaching, and if the physician has no choice but to choose between two patients, then these are the criteria. So now, if you are going to choose and no other option, then number one, first patient should be chosen. So they considered this criteria: first come, first served. But this is unfair. Why? Because this is a procedural issue, not a normative issue. It doesn't have value to come first. This can be applied for, like, if some patients can put their names to get another kidney, because they can remain alive with one kidney, and it's long term, so they can wait, and we can follow this criteria, for example, as a procedural one in cases like this, with long term. But we cannot follow this during pandemics or emergency cases, because many elements or factors will play a role in this regard. It will be unfair, and this might cause other damages like violence, or traffic, or and at the same time we need to keep social distancing during COVID-19. Then each one will fight and then struggle to come first. So the second criteria is that the patient requiring emergency treatment should come first and prioritized. The third criteria, successful treatment is more likely. Where successful treatment is more likely, and so as you can see here, emergency treatment and successful treatment, where successful treatment is more likely. But how can give emergency treatment priority? What if this emergency treatment contradicts the second one? The patient who has emergency treatment, who needs emergency treatment, but there is a very low possibility to recover. What should we do in this case? It's not clear from the fatwa. So to need emergency treatment, it doesn't mean that you should be prioritized. It's not necessary to be prioritized. So it might be that, okay, there's no any possibility to recover. In this case, there's no benefit from prioritizing this person or this patient. So the order of these criteria is questionable, in my opinion. And at the end, they said that withdrawal of life-saving equipment in order to benefit a patient coming after is not permitted. This is a general fatwa and general statement. But what if, the question here, what if this patient will remain with this equipment and he is or she is unable to live without the machine? So what should we do in this case? What if the possibility to recover is very weak, while there are other patients who have greater possibility to survive? Should we keep this person on the machine and leave aside other patients? So many questions can be raised.
But Dr. Muetaz, if I can, I'm sorry.
Okay, go ahead.
Okay, so but the way I read the guidelines is different. So I read them not from the top to the bottom, but I read them from the bottom to the top. So I think the first point where the first patient should be chosen, I think this is just to set a general order, but that does not mean, according to the points that come afterwards, that the first patient should be chosen. I think that's the overall order, but we have all exceptions that are coming afterwards. So
yeah, but we don't deal with fatwas this way. So
okay, I'm sorry.
So this is the text. This is the fatwa again on the screen. So usually they start from, you cannot move to the second point unless, there is equality or similarity in the first one. Okay, so we cannot move to the second one unless if they are equal with the first one. So the first option is very easy to go with, and to, it's very simple. Okay, first come, first serve. But the case here is very problematic and complex, and they didn't give the issue what it deserves to analyze and discuss sufficiently. Okay, so anyway. Let's move quickly because we have 15 minutes left only. The fourth fatwa, the fourth example, which is a fatwa issued by the Assembly of Muslim Jurists of America. And you can read, this is a summary of the fatwa. I wrote here some quotations from the fatwa because it's detailed and it's very detailed and comprehensive. To help you to think of that, I rearranged the content in this order, as you can see. Their guidelines is as the following. So human beings have the same intrinsic value as a general statement, but in this emergency case, so these are the criteria to prioritize people. The degree of need, number one, it comes number one. So, and number two is the one with the greater likelihood of recovery. And number two, as you see, so number two is number three now, sorry. Those with the longer line, expectancy should be given precedence. And number four, first come, first served basis, except when it may lead to violence or give unfair advantage to those capable of arriving early at a healthcare facility. And the last one is resorting to random selection. So the values that they followed are based on the fiqhi maxims of benefits and harms, which these maxims include the following four rules. Number one is maximizing benefits and reducing harms. Number two is repelling bans is better than securing benefits. Number three is procuring the greater good by forsaking the lesser. And the last one is harm shall not be warded off by similitude harm. So what do you think of this? Do you think that this is more comprehensive and concrete, or what do you think?
I think the way they order the criteria, it gives better chances to people who need care more urgently. They have almost the same criteria that the previous one, or the New England Journal of Medicine. No, actually, I guess the one before it. But they have the same criteria that others have listed, but the way they order them makes it more reasonable, I think.
Mm-hmm. What about others?
I personally think that this one is a lot more clear in what their values are. I think that some of the other criterias used words just for the sake of like just kind of be very clear in terms of what they were referring to. So I think this is a lot more clear.
Okay.
Well, according to me, I think it's more structured than the previous one, but there's one thing I think it's really strange in here is that first come, first served basis, except when it may lead to violence. So if you're the second one and you turn to violence, it might be beneficial turning to violence for you, right?
I don't understand the same point that you get from this, but they're giving an option to follow this if all the previous criteria are equal, or we have different patients and all of them are equal with the old criteria, and then we have to choose what should we do in this case. So in this case, we will follow first come, first served.
Yeah.
Only if they are equal in all the previous criteria.
Yeah, I understand.
Okay.
But I don't get the thing except when it may lead to violence.
Yeah, it's a bit weird form to put it that way. I agree with you. Yes.
Yeah, just there's a bit of ambiguity over the first point, degree of need. There's a bit of ambiguity. How can we define that degree of need?
Yes, this is based on clinical factors. So the doctors will decide the degree.
Isn't that affected by the likelihood of recovery? It's a bit, the first 2 points are a bit mixed into each other. The degree of need and the likelihood of recovery. It's a bit, I don't know, which one priority. If we are based on evidence, yes, I understand, likelihood of recovery. That's how we define the degree of need.
Okay, yeah, I think they meant here by the degree of the need, they meant the sickest patients. Those who need, there are some patients who need emergency intervention, and there are other patients, they can wait.
Okay, so it's a matter of emergency. Then
yes.
From those who need treatment urgently, we go to the second step, right?
Yes.
Yeah, another thing that I saw in the previous slide, they mentioned decline the ventilator. Is it from the person who will personally decline, or how? Because it's not here. It's not mentioned here in the.
Yes, the person.
من باب الإيثار أو I don't know.
Yes, exactly. The person himself declined, and he wanted to give the chance for other patients to be prioritized. So it's a kind of ethar, yeah.
Yeah, so that patient should be here in the first should be included in the guidelines when we categorize it, or no?
So he can exclude.
He can
be excluded. In
this
he's
case. The first to be excluded. Yeah.
Yes.
Okay.
He preferred to be not prioritized.
Okay. Thank you.
Yes. So in this case, because we will have another value, which is ethar, to prioritize others, which is a very positive value at the same time. So in this case, we will prioritize others because he gave us the permission to do so.
So this Assembly of Jurists in America, they mentioned that as the first to be. Yeah. Okay. Thank you.
Excuse me, can we say the degree of need is different from maximizing benefits that mentioned in England?
Yes, it's different. Yeah, they are not the same. They are not talking about the same perspective here.
And I think it's the main point that make difference between the Islamic view and maybe the secular view, because it depends on the need, and it has more value to the human beings or something like that. And also we see in the UK guidelines about maximizing benefits in both, as you mentioned, in the recommendation and also in the values. And they keep talking about the maximizing benefits, and some things like human beings and the need that they mention here, I think, is missing. I think the degree of need is missing in the UK guidelines, and
Okay.
they are put value here about this here.
Yeah. Okay. So you think that this is more comprehensive and detailed?
Yes, for sure.
Okay. Okay. Now let's finally end with the last section, which is suggested framework and guidelines. My suggestion here is as the following. So, but before I list my suggestion, I would like to show you that it's very important to comprise between theoretical ethics and applied ethics. So in applied ethics, we are among case studies require answers and guidelines to be followed and put in practice. So applied ethics necessitate a theoretical framework to be concrete, consistent, and coherent. So this framework of moral judgment requires three components, as I stated in the previous lecture, if you remember. So number one is identifying the governing values and principles. Number two is setting the criteria for balancing between different values, since there is no just one value here. The third one is providing ethical justifications, or reasoning, to guarantee that it is systematic. I mean, our suggestions or recommendations or guidelines are systematic and coherent on the one hand, and it is aligned with the lawgiver will on the other hand. Because within the Islamic studies or within the Islamic framework, so we have to keep our eyes on the lawgiver will. It's not just our worldly matter to decide here. So these are the key three points that the framework should contain or consist. Now, the rationale of this methodology is as follows. Fair allocation requires a moral, multi-valued framework because its complexity and interdisciplinarity. And values and principles are general, so it can be operationalized in different and controversial ways. Therefore, we need criteria to put it in action, number one, to balance between multiple moral values, number two, and number three is to be aligned with the resources and context in question. So based on this theoretical framework and key points of this methodology, now we can move to, I will give you the result of my framework, which I suggested now. So based on this framework, I would suggest what you see now on the screen. Now, the number one is the guidelines and criteria. So the guidelines and criteria are put in order. Number one, we should look at the patient's will. In case of the patient prefers to give priority to others, So in this case, the patient is motivated by the value of altruism, ethar. So because here we are among another value, which is ethar, altruism, and then we should take it in consideration. And if he chooses to be excluded or to wait, not excluded totally, to wait, then okay, we have to listen to this, to his will, and to respect his value that he's seeking for in this case. Now, number two will be the people with a higher possibility of surviving. Number three will be the sickest people who need emergency intervention. Number four, will be healthcare workers who will be able to help us to save more lives under this condition, not in general. Not every healthcare worker will be prioritized. So the prioritizing here is based on their benefits to others, not because their lives are more worthy than others. So it's very important. This point is very important. So I'm not going to prioritize every single worker in hospitals and in different sections of treatment, you know. So now, the number 5 is random selection. If all patients are equal in the previous 4, then we can move to number 5. To avoid being biased or to avoid being biased or manipulating or abusing the system. These are my suggestions. So I have justifications for this, but I will leave it now because we don't have time, and I will leave it for my research on this, which I'm working on now. So the values that we are seeking here are, as you see, there are three key values. Number 1 is saving the most lives. Life itself is valuable, so I'm not going to prioritize people based on the quality of life. So because life itself is valuable. Number 2 is justice and equality. So human beings have the same value, so we have to respect this, and we cannot prioritize some of them over the others unless we have concrete and clear justifications and criteria. In the emergency case, keep in mind that we are talking about emergency case, and we have to choose, and we have no other option to do but to choose between these patients. The third value is supporting and treating patients is a moral duty. So, and we have to, and this value is restricted to the capacity. So, and the need. So it's not just restricted to the need. Maybe I can, you know, I have this duty, but I'm unable to treat all these patients at the same time, because at the end, I have a capacity, a very limited capacity. So these are the values. So to explain how these values are achieved through the 5 criteria that I already mentioned or listed, it takes time. So, but in general, to end up with this sentence, so ethical justifications will justify and explain the philosophy and rationale behind this framework and why we prioritize number 1 over number 2 and number 2 over number 3. So these justifications are built on that I didn't mention, the justifications that I didn't mention, but they are built on fiqhi sources, including themes, juristic themes, maxims, precedented cases, and juristic reasoning. So that's it. Any other comment before we maybe I took 5 minutes over the time. If you would like to...
I just have one question. So what if the patient's will was not motivated by altruism?
In this case, we cannot consider it.
Okay.
If we have evidence or indicators saying that, you know, he wanted to, he have another negative value, negative motivation, like being suicide, intihar, right? Rasha?
This is what I mean.
Yeah. So in this case, we will not consider his will, because his will, from within the Islamic perspective, his will is unrespected, and it has no legitimacy. In this case, if we have specific indications or information that, okay, this is his objective. Okay.
Okay, thank you.
Assalamu alaikum.
Yes.
I just want to ask one question. Guidelines, right? Are they based on the context that?
Sorry, there's interruption. I cannot hear you well. Can you repeat the question?
Okay, so I just want to know: is this based on all resources being exhausted, or all avenues have been exhausted, that it got to the point now where you are in a situation of medical rationing, like they haven't set the sector's financial resources to allocate it to the medical towards medical funding to increase capacity, that these guidelines would be applicable from a fatwa perspective and from your development of these guidelines?
It's not clear to me because of the voice. Sorry. Can anybody explain to me if you heard her question well?
Roshana tried to write it because it was also difficult for me to listen to your question. Thank you.
There are some questions, written questions here. Can you write it down? Only when options for increasing supply are exhausted. Yes, of course. Yeah, we said this at the beginning. So all these discussions and criteria, they can only apply when there is the health system is exhausted and there is no enough resources to cover and treat every patient. But what should we do during this emergency case? The government has a moral duty to get enough resources to cover all the needs. And as for doctors, they have to re-evaluate and assess the system day by day, based on the scientific factors. So that they know the number of patients, the number of resources that available, and how many beds that we have. Maybe some people will recover and some people will die, and so it's an emergency case, and it should be evaluated and updated day by day, if not more than that. And at the same time, the state has a role to recover and to get enough resources. And as for people, public people, they have a moral duty to take all the medical tools to prevent increasing the number of patients, like taking all the medical instructions to preserve their lives and to not put traffic on the health system. In this case, they have a duty to do this. And it's a moral duty for each person to take all the sufficient tools to avoid this getting this virus, unless this will put more pressure on the health system and will affect others. So now we talk about, during this emergency case, we have 3 duties: the duty of the state, the duty of the doctors, that they have to assess the situation and the sources every day, and the duty of public people to not provide more pressure or cause more pressure on the health system during this emergency case. And this clarifies the point that I already explained in the previous lecture, the difference between normality, necessity, and emergency. So with emergency case, we are taking very harsh and difficult decisions. They are exceptional and very restricted, and should not be normalized. So, and it should be very limited, and at the same time to try to get out of this emergency case and take all the necessary strategies and plans, and put plans for this. This is the case. If this was your question. Okay. So this is the end of the discussion. I hope that it's clear and benefit for you. So, and hope to see you again, inshallah, in another lecture or meeting or whatever, or any other university. So have a good night, inshallah. Assalamu alaikum wa rahmatullah.